Hello and welcome dear learners to the NPTEL course on Healthcare Quality Management, Infection Control and Patient Safety. In continuation with the Module 3 discussion, we will be starting today with the Chapter 30, that is Infection Control Practices Part 6. In this chapter, we will be discussing on prevention of Ventilator-Associated Pneumonia, that is called as VAP, and prevention of surgical site infection, that is SSI. So, in prevention of ventilator-associated pneumonia, that is VAP, we will see the revised CDC guidelines for the VAP bundles and the backgrounds and issues with previous definitions. So, when we call VAP, that is ventilator-associated pneumonia, which is a lung infection that develops in a patient who are receiving mechanical ventilation. That is via an endotracheal or tracheostomy tube. So most of the reasons of developing infection is more because of this intubation or the tracheostomy surgery. So this infection occurs when an organism enters through this tube and reaches the patient's lung. It can be a cross infection, it can be transmitted by the hospital or healthcare employees, or it can be even acquired to the patient actually during the procedures. What are the background and issues with previous definition? So before 2013, the NHSN system tracked only VAP with wide variation in the reported incidence, that is 0.0 to 4.4 per 1000 ventilator days in 2012. There has been no universally valid or reliable definition for VAP, and commonly used criteria are neither sensitive nor specific. Earlier, NHSN PNUE definition relied heavily on chest radiograph findings, whether the pneumonia has developed or not, which are often subjective and consistent due to variability in techniques, interpretation, and reporting. So, what you need to work on with respect to the previous definitions and now in the current development? So, radiographic findings alone cannot accurately identify the VAP, making them unsuitable for standardized public reporting or comparison across the facilities when you have to compare and check the association with the other patients. Challenges in existing VAP definition. So, many definitions depend on clinical symptoms and signs that are subjective and may be inconsistently documented. The NHSN PNU protocol includes multiple pathways and special criteria for specific population such as children or immunocompromised patient, adding complexity to the surveillance, which becomes a little difficult task for your team. So you can see the display of ventilator associated pneumonia events and surveillance algorithm. So you may find that a patient on mechanical ventilation and baseline period of stability or improvement. And next to that, after the baseline, patient has at least one indicator or worsening oxygenation. You may find increase in daily minimum FOI over base sustained and this calendar days, or increase in daily minimum PPE of baseline sustained versus the 2 calendar days. So you may see with this you may come across with ventilator associated events. What is ventilator associated condition where patient meets both the criteria number 1 and the criteria number 2? When you find infection related ventilator associated complications on or after a calendar day 3 and within 2 days of worsening oxygenation on one of the following criteria is met. Criteria 1, positive culture with quantitative thresholds. Criteria 2, purulent respiratory secretions. And criteria 3 may be other positive diagnostic tests. The possible ventilator associated pneumonia, the patient meets criteria for VAP and IVAC. And criterion 1, where you may find this ventilator associated event surveillance algorithm will give you the entire understanding that how to tackle this infection. On or after calendar day 3 of mechanical ventilation, within 2 calendar days before or after onset of worsening oxygenation, and patient meets both of the following criteria, that is 1 and 2, you will get a ventilator associated condition. And here on you have to work on checking it actually how to reduce it. So the patient meets a VAC criteria only on after calendar day 3 within the 2 days of worsening oxygenation. Criteria 1, criteria 2, criteria 3 are displayed over here. One of the following criteria is met excluding the protocol defined organisms. Infection related ventilator associated complications will start here on. When the patient meets criterion for VAC and IVAC on or after calendar day 3 of mechanical associated ventilator and within 2 calendar days of worsening oxygenation, one of the following criteria is met excluding organism in the protocol, that you may see in the criterion 1, criteria 2 and criteria 3. Possible ventilator associated pneumonia. Now we will be discussing on prevention of surgical site infection, that is SSI. A surgical site infection occurs after surgery at the site when the operation was performed and may involve superficial tissues, deeper structures, organs or implanted materials or any of these. So despite advancement in infection control, SSIs remain a major cause of morbidity, prolonged hospitalization and even death. So surgical site infection can be seen as a major problem in infection control practices. Surgical site infection account for a 3% mortality rate and 75% of the surgical site related deaths that are directly attributable to this infection. What is the importance of SSI surveillance in a healthcare setting? It is to continuous SSI surveillance with surgeon specific feedback is crucial for identifying risk and guiding prevention strategies. Effective surveillance requires strong definitions, appropriate data collection and stratification of the SSI rate by risk factors. Do surgical site infection prevention strategies have a core measures? Yes, it is. What are the pre-operative measures? So, administer a antimicrobial prophylaxis according to guidelines. Ensure that the dosing is within 1 hour before incision. 2 hours for vancomycin or fluoroquinones. You can see a newer generations also. Select prophylactic antibiotic based on surgical procedures and likely pathogens. Identify and treat remote infections based elective surgery. Postpone surgery if infection is unresolved. Avoid hair removal unnecessarily. If required, use clipping or depilatory creams instead of razors. Use appropriate skin antiseptics and proper skin preparation techniques. In line to that, maintain immediate post-operative normothermia. For colorectal procedures, mechanically prepare the bowel. Administer non-absorbable oral antibiotics a day before the surgery. What are the intra-operative measures? Maintain operating room discipline by keeping the OR door closed except when essential. What are the immediate post-operative measures which needs to be followed, such as protect primary surgical incisions with sterile dressings for 24 to 48 hours. Control post-operative glucose, aiming to keep the level less than 200 mg per dl, measured at defined intervals. Discontinue prophylactic antibiotics within 24 hours post-surgery, that is 48 hours for cardiac procedures can be seen as. So surgical site prevention strategies which can be supplemented actually as a measure where pre-operative, where you can say high risk or specialized procedure. screen for Staphylococcus aureus, which is a major burden, carries and decolonize using mupirocin in elective cardiac or orthopedic, neurosurgical or implant related procedures. Monitor and maintain strict blood glucose control during POD 1 to 2 for selected elective surgeries. Redose antibiotics if the procedure lasts more than 3 hours. Adjust antimicrobial doses appropriately for obese patients with BMI more than 30. Use more or less 50% of inspired oxygen inoperatively and immediately post-operatively when indicated. What are post-operative supplement measures? Provide surgeon with feedback regarding the individual SSI rates. Implement active patient-based prospective SSI surveillance. Include post-discharge monitoring. So what are the methods for detecting? The methods can be direct wound examination during the follow-up sites or review of medical and clinical records. Surgeon survey by mail or phone, which is very important actually to see and understand. Patient survey by mail or phone, which will give not limitations in patient assessment. So at last, to this particular chapter on ventilator-associated events, we need to see that the healthcare workers need to provide an objective standardized system to monitor the complications. Complications in mechanically ventilated patients, replacing subjective VAP definitions which are to be seen with the challenges that we are facing with respect to the huge increase in the VAP infection. The ventilator-associated events progresses through 3 tiers. One is the VAC worsening of oxygenation, IVAC that is infection indicators plus new antimicrobials, and the PVAC that is laboratory evidence of pneumonia versus to actually what the physician is facing about. The traditional VAP definitions relying on radiographs and clinical signs are unreliable, prompting the shift towards ventilator parameter based surveillance, which is very important now to make a culture on developing in your institution about ventilator parameter based surveillance. Surgical site infections remains a major cause of morbidity. You may come across many institutions who have seen or witnessed as a major issue with respect to HAIs. This can see major load on the patient that a patient's prolonged hospital stay is mostly because of this infection, and many times it has been reflected even resulting in mortality. So despite all the advances in the surgical practices, surgical site infections has been seen as a major cause. Prevention strategies are very important to tackle this SSI, and that can be seen as a very important way to deal with this. What are those prevention strategies? The strategies can include appropriate antimicrobial prophylaxis before the surgery, at least before 2 hours of the procedure to be started, strict intra-operative practices, which is very important, which has been displayed actually and has been emphasized more in the previous sections. Proper post-operative care is very utmostly important actually to develop as to be seen among the staff who take care of the post-operative care of the patient. And supplemented measures such as Staphylococcus aureus decolonization, tight glucose control with patients specifically who are with diabetes or with a BMI more or obese patient or immunocompromised patient, and surgeon specific SSI feedback is very important when you try to take a decision based on what are the lacks. So thank you for the patience listening, and try to emphasize when you are developing a chart or even developing a module or training in your hospital to work on all the references which are being given, and make sure that the infection control practices for your healthcare worker should be a very standardized practice. So thank you for the patience listening.